So it's a great pleasure for me to welcome you to a very exciting satellite symposium, kindly supported by Erbe, and I thank the whole Erbe team for assisting and for organizing this event between the live sessions. I think we can still expect more participants, so many are outside to grab some food. And we have I think, an important and interesting topic on utilizing new technologies for GI lesion management. And it's an honor for me to moderate together with Roberta Maselli from Humanitas Research Hospital from Milan, and Yutaka Saito, whom you have already seen this morning doing a wonderful ESD, and he still looks very relaxed. So. And he is from the National Cancer Center in Tokyo. Now, as you have seen in the program, we have 3 lectures and should have enough time to discuss in between and after the last presentation. And our first talk is from Stavros Stavropoulos. He is now in Thomasville in Georgia in the Archult Memorial Hospital. And Stavros, thank you so much for joining us. I think you pre-recorded your presentation, but thank you for accepting to be online for questions and discussions. Welcome.
Yeah, thank you, Horst.
We can see you well. Yeah.
Thank you.
You look very serious in your nice suit. Yeah. It's not the typical American way at lunchtime to sit there with a tie, but we very much appreciate. Okay.
Well, it's 4 a.m. in California.
I'm sorry. Yes, that's okay. Okay. So then, shall we start your video and then
yes,
we
please,
discuss your presentation, please.
Mm-hmm.
Thank you, Horst and Erbe, for inviting me to the legendary Düsseldorf course. It's a great honor. I will talk on optimal current selection for POEM based on my experience of over 900 poems using the Erbe generator and the hybrid knife. Let's start with the first step, mucosal incision and tunnel initiation. My preferred current is dry cut, which has a much cleaner, crisp cutting on the Vio 3 than the Vio 300. Its advantage, it's a hemostatic cutting current. The initial mucosal for POEM is blind to submucosal vessels. Use of less hemostatic currents, such as the endoCUT, can result in sudden copious bleeding from vessels within the incision, which can be difficult to visualize and coagulate. The disadvantage is that it causes a wider thermal injury than endoCUT, and it can look not as elegant, particularly if there is extensive contact of the knife because it's tangential to the mucosa or if a thicker knife is used. This is more important for ESD in achieving a good margin, not so important with POEM. So you can see here a video that shows use of dry cut to initiate a POEM. I enter with a puncture wound where if you hit a vessel, it can be much easier to coagulate than a slice. Puncture is better. And then we enlarge this to an oval opening that can make entry into the tunnel easy, and also closure with suturing, which is our go-to technique for closure. Now, in this POEM, it's anterior POEM. The knife is more tangential, so we are tempted to use endoCUT to get the cut going. And maybe predictably, we'll get into some bleeding soon enough. You can see blood in the incision. It can be difficult to localize it and control it. Sometimes even requiring a Goa grasper. Here we switch to dry cut and go to the edge of our incision where the bleeding started, and then stay almost in place and do some dry cutting. Unfortunately, it was probably a sizable vein, and that easily controlled the bleeding. Now moving to submucosal dissection and tunneling, preciseSECT is our go-to current for normal submucosa, especially small vessels are present. The preciseSECT is a blue pedal current introduced with a Vio 3 that is a smart current that utilizes the massive computational power of the Vio 3, 25 million calculations of circuit impedance per second, to modulate the current into a cutting current when there is vessel-free submucosa, and more coagulating current when vessels are encountered. So it's a very hemostatic, precise cutting current. It's a smart current that modulates properly. Disadvantage is that it has poor cutting under saline, what some people call underwater. And another disadvantage is that it doesn't cut very well through dense fibrosis and risks mucosal heat injury. endoCUT is very good in these scenarios, precise cutting in areas of fibrosis that have low conductance. And also, it's the only current that can reliably cut under saline. For example, when we use a water pressure technique in POEM, particularly near the EGJ in a tight sphincter that also has severe submucosal fibrosis, underwater technique could be useful, or under saline. Disadvantage, you can get diffuse oozing from even small vessels, less hemostatic than dry cut. Another disadvantage is if you accidentally hit the mucosa, even with a single pulse, you can create an injury with endoCUT, more so than the coagulating currents. Now, this video shows preciseSECT dissection. You can easily take care of submucosa and even low-risk vessels such as this vein with just the preciseSECT smart current dissecting through the tunnel. Very effective. This is a different scenario, severe fibrosis in a difficult POEM. Also very little space due to a tight sphincter. So here we utilize under saline technique, which provides magnification, mucosal protection from heat injury, and also low insufflation. endoCUT is very useful. It's as close as you get to a pure cutting current, which is needed due to the low conductance of scar tissue and also the dispersion of current by the under saline technique. It's also important that we're using a hybrid knife because the powerful injection can create a submucosal plane, however small, that can guide the dissection where very little submucosa is present due to the fibrosis and the tight sphincter. And you can see we can enter in the cardia this way. In this situation, we avoid blue pedal currents, such as preciseSECT forced or sprayed, because the dissection is often very close to the mucosa as seen here, and you can get accidental heat injury and partially cook the mucosa and then even without direct injury, you can get the delayed perforation. And I have an example of that in this case. This was an 11-year-old Down syndrome girl that had 2 prior pneumatic dilations at 4 and 6 years old and an aborted POEM 6 months before our redo POEM, which was done actually at our live course by another expert that could not get into the cardia due to the extensive fibrosis. So we undertook the POEM. It took about 3-4 hours to complete it. Very difficult dissection. You can see from the lift here how much fibrosis there is. This opaque, milky, greenish lift, fibrosis at the entry. And then during the dissection, you can see all this underwater technique here, very difficult to visualize planes. We followed the greater curvature approach and we're able to get to the cardia, as seen here on the transillumination. On the way back, however, you can see purple mucosa here that looks devitalized, risk of delayed perforation. We put fibrin glue because of this reason in the tunnel before closing it. And something we don't usually do, we did a redo endoscopy in a second look endoscopy in postoperative day 3. You can see near the EGJ, there's an ulcer now, and there's fibrin glue protruding from the ulcer, so thank God we placed it. However, the sutured closure at the top of the tunnel is intact. So basically, we kept the patient NPO for a week with antibiotics and sent her home. And she's doing fine 2 years later. But you have to be on the alert for this devitalized mucosa. Now, let's move to hemostasis and vessel coagulation. It's important to be able to differentiate veins that can be, as I showed, easily coagulated even with preciseSECT as you dissect the submucosa, from arteries that need special treatment. Veins, dark red, bulgy, soft and collapsible. Arteries, thick-walled, rigid, pale, firm, pulsatile, and often with this whitish sheen on them. Now, this is our hemostatic matrix for scenario, device, current, and technique. If you have small arteries, tiny ones as shown here, they can or pinpoint oozing from the muscle. You can use the knife with spray as an APC-like non-contact spray technique, works well. Now, if you get to medium arteries, experts can use the knife to coagulate them. by doing the broad contact flat side of the knife on the side and using ultra low power preciseSECT and force. This achieves slow cooking with no spark generation to avoid prematurely rupturing the vessel before it has been coapted. If it's underwater, you can do the same exact technique with a knife, but here you need to use spray at regular settings, which end up working exactly like low forced under air. Now for large arteries needing preemptive coagulation, a coag grasper should be used even by experts. Again, it's important to just grab them with a very tip and tent them to avoid diffuse thermal injury. I'll show you a video on that. And finally, if you accidentally cut an artery, for example, it has been widened out by coagulation near it and looks like muscle and you cut it, or it's at the edge of the tunnels where it can hide and be cut. There, I think using a bigger grasper like a hot biopsy forceps can allow you to grab less precisely but more effectively when time is the essence, so you don't cover everything with blood and you can hardly see the vessel. So, hot biopsy forceps with a big grasp. Less elegant but very effective. Now I'll show you a video of these techniques. This is the spray non-contact technique for minor bleeding. Easy, and here it's the muscle, so it's safe. Now here we accidentally cut a vessel on the myotomy. You can see pretty rapid bleeding that threatens to cover everything with blood before you can see where the vessel is. So here having a big forceps with a big footprint that covers this entire area without being super precise can get control quickly. Now I'll show you the slow cook technique with a big penetrating, well, medium-sized penetrating arteries using the side of the knife. It's done a little too fast here. Normally you should leave the submucosa uncut and spread the current along the submucosa and the vessel. Here we cut the submucosa off first, so there wasn't much tissue, so the current density was still high enough that we didn't get a perfect result, but good enough. There's some bleeding from the other half of the vessel that you'll see near the mucosa. It's a little more dangerous, but same technique with the knife, the side of the knife. We inject first under it to protect the mucosa, and then we use the side of the knife with as much contact as we can and forced, which takes care of it. I'll show you a better application of this technique on a larger vessel, which contains veins and arteries. Again, using the entire knife to achieve very low current density and very low force. You can also use very low preciseSECT. It's pretty much the same effect. And then you can step on the pedal for quite a while and be patient to allow for the slow cooking technique to work. The veins are easily and immediately, as you saw, shriveled down, but then you have the arteries that still are alive to some degree with a little bit of lumen there probably, and those very muscular arterial walls. So, we proceed with further low forced or low precise and take care of it. Now, this is what I was talking about in terms of very precise grabbing with the tip of the forceps. When you're using forceps coagulation, catching with the very tip of the knife achieves very high current density right there, and the soft algorithm prevents further thermal damage because as the conductance goes down, the injury stops, very little energy delivered, very effectively. If you catch a lot of tissue, now the current has a broad area to escape. You have low current density and broad current flow, and that can spread the thermal insult significantly. That's a video courtesy of John Day. Finally, on the myotomy step, for full thickness myotomy, preciseSECT is good because it's a hemostatic current that can coagulate this ladder of vessels that often lie between the muscle and the pleura to avoid bleeding from these vessels. Some experts use spray. You have to be careful with spray. If you accidentally overshoot, you can cook the mucosa. or even if the muscle touches the mucosa, even there's no direct knife contact, the spray can injure the mucosa. For circular only myotomy, endoCUT or dry cut can be used because the circular layer is relatively avascular, and endoCUT achieves more precision to be able to maintain the longitudinal layer. So I'll show you 2 videos of this. To the left is a full thickness case with preciseSECT. To the right is endoCUT doing a circular only myotomy. You can see here the deep vessels on the left that we are avoiding or coagulating using preciseSECT, or as I said, sometimes spray. But spray, you have to be careful. On the right, we're doing an anti-reflux poem, our patented anti-reflux poem. We presented our case control data, 116 anti-reflux versus 116 conventional, 50% less reflux by pH study, and 3/4 of them. And you can see we're doing the circular myotomy carefully with the endoCUT, very precisely. It's very avascular, the circular layer. Unlike the vessel, all the vessels you see on the left lurking under the muscle, here it's pretty avascular. And you can see the anti-reflux poem very well demonstrated. To the left, you'll see the Tanaka vessels, that is three sets, that are the landmarks, to the left of which is the sling fibers that we're preserving. It's a very effective anti-reflux technique. And that's the end. I'll leave you with the sunset from the island where my family is from, in the Aegean Sea in Greece, Nisyros. It's a volcanic island. Thank you.
Stavros, thank you very much for your clear demonstration of the latest technologies, also different kind of settings, which is sometimes difficult for those who have limited experience with ESD and POEM, but you explained it, I think, very well. Could you just comment on the impact of the size of the knife? So how does the conventional Erbe knife compares with, for example, dual knife from Olympus? So it's a different diameter, and what impact does it have on dissection and cutting?
Yes, thank you, Horst. So you're correct. The current density is affected by multiple factors, including how much of the knife has contact, but also the diameter of the knife itself. The hybrid knife is, I believe, 0.7 millimeters in diameter for the knife. The Olympus, don't quote me on this, but I think it's 0.5, I believe, or maybe it's 0.4, I'm not sure, the dual knife. So I think it's a substantial difference. You know, for example, when you use the vessel coagulation technique, the slow cook method, what the Japanese called, you know, the F110 on the old Erbe, which is forced current effect 10 watts, so F110. The knife size makes a difference. If you try to do it, for example, with a hook knife, you may have to be a lot more careful than if you try to do it with a hybrid knife because of the difference in the profile of the knife in terms of diameter. So I think, yeah, you have to take this into account when you apply this kind of methods. I think that's the most important. And then on ESD margins, you can get a more heat artifact if you use an Erbe, which I use, for example, for some gastric ESDs and occasionally for some esophageal ESDs. You have to be a little more careful with the margin if you're going to use dry cut to enter than if you say you are in the colon and you are using the dual knife. So I think, yeah, the diameter of the knife has to be taken into account.
Okay, thank you. Thank you for this clear explanation. Are there any questions to Stavros? Unfortunately, we are already a little bit out of time. So thank you very much again joining us this early morning. I wish you a wonderful day. Maybe you can stay with us until the end if there are additional questions.
Yes, thank you, I will.
Okay, I'd like to introduce the Professor Roberta Maselli from Humanitas Research Hospital. Milan, Italy. Her topic is hybrid knife for upper GI procedures. Please join us.
Thank you. Good afternoon to everybody. Thank you for the invitation, and thank you also for this introduction. So I will try to share with you my experience with the hybrid knife for upper GI procedure. Let's say with the hybrid knife that up now we know, because you know that we are coming with a new knife, so I will try to save this knife for the upper GI procedure. First of all, I want to say that basically we can divide the ESD knife into two main types. We have the insulation tip knife, that is the IT, and the non-insulated. And then further, we can divide in those without injection or with injection. The fact is that if we want an injection function, then we have the high pressure injection, that is a machine that is able to, with a pressure, inject our saline or what we want to inject, or the so-called standard pressure injection, that means via syringe or with a pump. And the hybrid knife up to now is the only one that have those both types, so the insulation tip with the type O, but also the not insulated into two different versions, that is the I type and the T type. And here we are the current knife we can use from Erbe, from the hybrid knife. Again, the O type, the I type, and the T type. But they are working together with an electrosurgical unit, that can be the latest one, for example, the Value 3, together with the hydrosurgery unit, because the concept is that through the knife we have two different pathways, two different ways, let's say. One is to the electrosurgical unit, the other one is to the hybrid jet, that gives you that injection we were talking. And let's see in the upper GI when we can use this hybrid knife. So Stavros already said a lot about poems, so I don't want to go deeply because he already said almost everything. Just let's see a short video. Thank you. So here I'm using the T-type, that from the three is one of my favorite one, but then I will show you also a video with the I-type. And you can see that the current is going exactly when you are pointing with your knife. So there's not so much spread. It depends, as Stavros was saying, on the current you are using, but most of all, you can be very precisely, because it depends on the technique, not only on the knife. Of course, it depends also from the knife, from diameter, from other function. But with this one, you see I'm injecting, and later on, in a few seconds, I'm able to dissect, and also later on to make also the myotomy. So with the same knife, we can do all the steps, unless we encounter a very big vessel and we need to change to a coagulation rasper differently. So we can do the mucosal elevation, but also the hemostasis in case we found some vessels, the submucosal tunnel, the myotomy, and finally then we will close with clips. Let's see in the literature if we found some data about this, and I found this paper from the Chinese group, and they said that comparing a poem with hybrid knife and with other knife, we have a significantly shorter time of procedure for the hybrid knife group because of less replacement of accessories, because you are using just one knife to do all the steps you need. At the same time, the injection volume was larger in the water jet group, and this was associated with fewer minor bleeding episodes, because mainly and maybe if you are injecting a lot, you are able to see the vessel and to manage that vessel in the proper and the correct way. And I will show you also a video about this. Again, one paper, this is again a Chinese experience, and again, significantly decrease in poem procedure time and facilitates reinjection, possibly contributing to a lower rate of minor intraprocedural bleeding. You know, so with this knife, we can be faster, and let me say that to be fast is important, not just because we are cool and we do something very fast, but because it means less time in the body of the patient, less gas-inflated and gas-related adverse events, and in general, less adverse events for our patient, and also an enhancement recovery time for the patient. some other case control study, but all of them, they are mainly arriving to the same conclusion that you can be faster because you are not exchanging all the time the device, you are doing everything with just one. And finally, we arrived at this systematic review and meta-analysis, more than 500 patients, and again, fewer instrument exchange and use of coagulation forceps because injecting more, you are able to see the vessel and to manage in the proper way. But in the esophageal side, we also can use the Erbe knife for this stair, for example. I found only this article. Unfortunately, it was not full published, was not a full paper, but only an abstract. But they were applying and trying to understand if using hybrid knife or not, there were benefits. And they found the benefit for the same variables we saw in POEM. So the operating time was significantly shorter with lower frequency of instrument replacement, and also the number of hemostatic times requiring for intraoperative bleeding was less for the hybrid knife. And let's see my experience for what I've done for the this guest that was in the cardia. And I want you to focus on the details. Here I'm using the T-type. So I'm getting the access proximal to the lesion, injecting with the same knife, and then while injecting and dissecting, I'm trying to expose the tumor. And step by step, I was disconnecting the tumor, trying not to make injuries on the gist to remove it. And when it's completely disconnected, I can remove it. And simply, after the final check for hemostasis, I will close the entrance with clips. What about esophageal ESD? So let me show you this case to you. This is a circumferential ESD for an SCC of a 78-year-old lady. And after the lugoiodine, I know that Professor Roche was performing an esophageal ESD this morning live, so it's nothing different, just the knife that we are using. Here we are using the hybrid knife, and I'm using the I-type. Because of the shape at the end, let me be very precise. Here, if you see, I'm marking with the knife outside, completely outside. In the gastric ESD, you will see that I'm using to mark with the knife inside, so to use the T just to touch the tissue and to make small marks. So it's true that the shape and the length is different from any other commercially available knife, but also it depends on how you use your knife to make it precise and exactly what you want to do. So after the mark in the distal part and in the proximal part, you will see that finally was around from 24 to 23 centimeters from incisors, so it was a very long procedure. So without changing the device, I was approaching the distal part. I was just injecting a little bit. Sometimes I do it with a needle, but then with this one, I'm able to inject. An injection makes me feel safe because I know that only the submucosa, once injected, get elevated. So if the elevation is there, it means that that plane is the submucosa, and I can cut easily without any fear of mucosa, of muscle injury. And later on, I'm coming back in the proximal side with the same knife. I will inject. Using, for example, one of the mark I already done, because that one is a small injury in the mucosa, and also why not to use it to make the injection? And here we are. But later on, I will cut a little bit farther from the mark to have a marginal normal mucosal side to be resected together with my lesion. And you can see how I can inject and dissect, inject and cut. I will go a little bit farther, otherwise it will be too long. So once I reach the tunnel, the exit of the tunnel in one side, I will approach the other side to have finally two very long tunnels, as in the poem, as in this way. And then I will connect the two tunnels I've done. Sometimes I use a clip, specifically when I'm doing the circumferential esophageal ESD, not to have the lesion that is collapsing down for the gravity of the esophagus and you are missing your plane and you are not understanding how the tissue is responding to your cutting, because we are like cutting, I will say, we are cutting a steak without the fork, just with the knife, and while we are cutting, the steak is moving, so you have to, like, three-dimensional understanding what's going on while you are cutting. And at the very end, you will see that I have only one small tissue that is connecting all this long ESD. And again, with the same knife, I cut it, and this is the very end of the procedure. Later on, I will inject triamcinolone to prevent esophageal stricture, and we are happy with it. So what about the cardia ESD? So here, the ESD is a little bit tricky because you know that sometimes, most of the time maybe, you have to work in retroflexion, as in this case, and thinking of the gravity, you have to work before in the section of the lesion in the oral side, that means in the gastric side, and then later on to come back in the esophageal one. And here you see I'm using a T-type, I'm working in retroflexion, and this is something that a lot of people is saying about this knife, that is too stiff and you can't work with a hybrid knife in retroflexion. Well, let me say that it's not true, this is just my personal experience, but this is what I think. Because sometimes the gastroscope is too flexible, and having a knife that is a little bit stiff gives you stability. It depends on how you use it, as always. So, as you can see, I'm able to mark, dissect, inject, coagulate, and do everything. This is what I call one device ESD. So with the same one, you can do really whatever. Just sometimes you have to replace with a different instrument. And I will go further, otherwise it will be really too long. Here I am in the esophageal side, so the proximal side, and I'm using everything I have, even the cap, to stretch the tissue and to understand the remaining part, and this is done. So what about gastric ESD finally? So the upper GI is all there. I found some data. So again, we have, this is from Professor Neuhaus' group, we have data regarding the comparison of gastric ESD with hybrid knife and without hybrid knife. And again, we have a procedural time that is significantly shorter with a hybrid knife because of the change of accessory was less frequently required. So exactly the same conclusion that we are having in the esophageal side is the same also for the gastric side. Some other articles, again, from the same group, but the conclusion is exactly the same. And so let's see, the next speaker will be Jéremié. So Jéremié, I think, and I hope you are online with us, this is a tribute to you, because in this video, I'm using the bench traction that he invented. See, here I'm using just the tip of the knife. It is a T-type without putting out the knife. Because of the T-shape, I can just compress the tissue and apply the blue pedal, and I will have my mark without putting out the device. Otherwise, can be really a little bit too risky because we haven't made the injection yet. So again, it depends on how you use a knife. But for upper GI, when most of the time you encounter very big vessel, let me say that you have a big knife to have a spray current giving you a good hemostasis, maybe is better. And we'll talk about hemostasis in next couple of slides. So with the tip closed, I will make the mark. Let me go a little bit farther. And with the same one, I can inject and try to enter in the third space, in the submucosal space, and I will inject and dissect very easily. Then here I applied, as I was mentioning before, the clip, the rubber band clip method to have the traction, to have the fork we were talking about that usually we don't have in flexible endoscopy. So I will attach via two clips the lesion on the opposite wall, and I will use this traction while inflating a bit or deflating to let this clip and this rubber band elevate the lesion. Just remember that once you are elevating the GI tract, you are elevating all the tract. It means also the submucosa. So still you have to recognize the planes. And this is why time, having a device that is able to let you inject all the time you need while you're not understanding which is the plane is the best benefit you can have with a knife. So injecting and then cutting the things that I already injected. And we'll proceed in this way. So it seems the best device ever. So do we really need a new device? The fact is that when I'm talking to our colleagues and talking about the hybrid knife, because I show you my current practice, the word that came to me is that rigidity is too rigid, or it's not so precise as other knives, or it's too long, or it's too big. But I hope that with my presentation I showed you that it depends on how you use the device, and especially in upper GI, we still need a device like this one that is long enough, precise enough, big enough, and rigid enough, because sometimes this rigidity gives you stability. So that goes together and in parallel. And what about coagulation? Really, the last slides I will show you. Stavros showed us the different cut modes and also the different coagulation mode you can have with the Bio 3 and the hybrid knife. And I will a little bit focus on the preciseSECT mode, because in my mind, this is what I do every time. Intraoperatively, I try to make a vessel detection before cutting, and here you need the injection to make a good detection. Then vessel preparation, so to expose the vessel and to have very less tissue that is in contact with your knife to have a very nice vessel coagulation. And let's see this one device ESD. See, the first step is vessel detection. So once I'm in front of the vessel, the first things I do is to inject and to try to separate the vessel from the submucosal tissue that I encounter. So I will inject, expand the submucosa, and you see I'm touching the vessel, but I'm not coagulating it. The vessel is becoming whitish because a little bit of coagulation is going there, but I'm not approaching directly the vessel. Before, I'm approaching the submucosa nearby the vessel to expose the vessel and to prepare the vessel to my coagulation. Again, I'm with a T-type, so while injecting, sometimes when I see this video, I think that is incredible, because I see now I'm cutting it, I know, and I'm not, because precisely the current goes exactly where I want it to go. So the third step is the coagulation. In the middle of the vessel, not too close to the muscle, not too close to the mucosa, I will face the vessel and with the stroke, let's say, of my knife, I will keep on cutting. And again, I repeat the 3 steps all the time. Again, one more vessel: detection, preparation, and just finally, when I have no other submucosal tissue around it, I will grasp it with a T and I will coagulate it. And all the time, it's repeat. So the key message of my presentation is that maybe we can talk about flexible rigidity. I know that it's strange to make these 2 words together, but it's what I think that the hybrid knife, the current hybrid knife, is giving to you. It's fast and safe, and be fast is important for patient outcomes. Maybe it's big knife for big vessels, and in the upper GI we have most of the time major vessels compared to colonic vessels. Not in the rectum. The rectum is a little bit different, so I will use this current hybrid knife for rectal lesion, but also for all the upper GI. And finally, for this custom injection that inject all the time, whenever you want, exactly when you want. Thank you.
Thank you, Roberta, for your wonderful presentations from the poem and also the STAR and the ESD for upper GI. So I'm sorry, so the time is very limited, so no question and answer.
So then it's a pleasure for me to ask the Professor Jéremié Jacques from the University in Limoges. Jerry, we can already see you. Thank you so much for participation. Of course, we miss you in Düsseldorf, so next time you should really be here. But we're looking forward to a lecture with the challenging title, The Knife of the Future.
Thank you so much, Professor Noyos. Thank you for the invitation. Thank you to the Erbe team. So I hope, yes, next year I could be with you. So I will speak about make colorectal ESD, why a new knife is needed to help us. why there is still a debate for en-bloc resection on all superficial GI tract neoplasia, in particular in the rectum, because it's technically challenging, it's perhaps more risky, more time consuming, and there is a debate about cost effectiveness of this strategy, but there is no carcinological region. Nobody can look into your eyes and tell you it is better to cut a potential tumor in a piecemeal fashion that is an en-bloc fashion from a carcinologic point of view. So the solution is to solve this technical issue. And how to solve this technical issue? It's use the right material, having a perfect tip control, have a nice exposition, a perfect exposition of the submucosa, and an adequate training. I will go fast for the training. We have this wonderful statement from the ESG that make a beautiful review and advice to how to train you. And I think nobody that begin ESD now in Europe could not be trained, as mentioned, ESG. ESD is quite like high-level sport. You cannot become Tiger Woods without a lot of training. The matter with training that you need at this time lab with pigs or ex vivo model, but I think it will be totally revolution by all these new training models that you can use in your endoscopy unit that come from Japan and that use tissue engineering. And we will now be able to train in a daily practice or fellow in the unit between the cases, and I think it will considerably change the expansion of ESD all around the Western world. For the material, the first step is to choose the right scope and to find the best combination between the outer diameter, the size of the working channel, the retroflexion ability, and the stiffness. And you need to adapt in colorectal ESD what you need according to the lesion. Sorry, there is not the picture. There should be a picture of the VIO 3. You have to choose the right electrosurgical unit. And the VIO 3, in fact, is like a engine, you know. If you take the two drivers from Mercedes, they have not the same setting. And if you take every driver from Mercedes, they are changing their setting according to the race. So it's quite the same with the VIO 3. And when you do ESD, you need to know how works your electrosurgical unit with the knife you are using, and according to the lesion, according to the vascularization, to the fibrotic part, and adapt the setting constantly during the procedure and between procedure. And only VIO3 can help you to do this. Then you need a perfect scope control, and your scope, in fact, need to be your end. You need to work with the perfect ending of the scope and with the scope in short and straight position. And that's why this ability to have a scope in short and straight position explain why colonic ESD is much more difficult than other location, also like duodenum part, because you need to be able to make shortening endoscopy and shortening colonoscopy. And in fact, since 40 years, Japanese master have told us how to write ending the scope, and it's the position of your left hand that is perfectly important, because you need to have your thumb that is all in the up and down angulation, but also that can reach across to the left and right control to have your right hand that is free to handle the knife for accuracy or the scope for torquing and combine. Here is what is making in practice. You need, with your left thumb and with your third finger, be able to move the two wheels to move your scope every time in a three-dimension fashion, and to have your right hand that can hold the knife and hold the scope. What are the tips that we can have in case of poor scope maneuverability? Because poor scope maneuverability is quite a nightmare for ESD. Is don't forget to turn the patient, in particular in the colon, in the right colon, because generally you have a better scope maneuverability in a supine position or in a right lateral position for right colon. Use tunneling technique like pocket creation method, because it makes you a stabilization of the scope under the flap, and use retroflexion that help you to stabilize the scope. You need to be able, not forget the C shape. All the GI tract is like a C shape. The angle of the C depends where you are in the GI tract, and you need to have your scope that will slide every time on the muscle. And to do this, you need to combine the left and right wheel and the torquing on your scope to have this quite of movements that keep your working channel at 6 o'clock. How can we now expose the submucosa? First is make a right injection. Don't forget that you don't want an injection and a surelevation of your lesion when you do ESD, but you want an elevation of your cutting line. So you need to inject far from the lesion to have a perfect elevation of your cutting line. That will help you. Then make a perfect incision and trimming. Not to be too superficial, because if you are in this red line that is muscularis mucosa, you will be in trouble with vessel, and it will be difficult to go in the space. And it is very difficult because it's a blinding phase. Use gravity and traction. Gravity is mandatory in the rectum, that increase the dissection plane, that avoid liquid stagnation, that avoid leakage in case of perforation. But in the colon, it is unsuccessful in 30% of cases, and it could also change the scope maneuverability. So in my team, we prefer have in the right colon, notably a perfect scope maneuverability than a help of the gravity, because now we work with traction. I always say the same. Have you ever seen a surgeon working only with one hand? Even if he is the best surgeon in the world, he will make triangulation with his left hand. So for us, traction is used on a daily basis in every cases, and the perfect traction should be independent from the scope, adaptive and removable, cheap, and go through the working channel. Don't forget that tunneling method was one of the first of natural traction developed. Don't forget also that ESD is it's a matter of tangentiality, and you need to try to work at 6 o'clock every time. It is the best position to be efficient and safe. You can work at 12 o'clock, but forget that your knife is more going in direction of the muscle layer, so you need to be more cautious, and you need to try to avoid to be perpendicular because it is dangerous. But how to do when you are in difficulty to be tangential? Don't forget these two aspects. Go to retroflexion. It will increase your stability. It will put your scope in a tangential position. It will decrease bowel movement, or use the pocket creation method because you could deflate the colon. You will increase the stability, and you will decrease the bowel movement and increase the tangentiality, as you see in this draw. Don't forget also to go deep in the submucosa to increase your vertical margin to the good cutting line and to decrease the risk of bleeding, because vessels, they are like trees that come from outside the muscle to inside the mucosa, and it's more easy to treat only these 5 trunks than to treat all this lot of bunches. Finally, the next step is having high pressure injection. Everybody that use one-time high pressure injection with the old hybrid knife say, I want to have high pressure injection in my daily practice. And I totally agree with Roberta that in the GI tract, the hybrid knife, in particular the T-type, is wonderful, and the stiffness is not a trouble. It is more difficult in the colon. But we have data that high pressure injection already help you. One of the first papers, the team of Germany that include Professor Yagi show on models that on pig models that the perforation rate was decreased by 5 using high pressure injection. Also something that could be important. Now we reject more and more deep cancer. It's the thickness of the specimen was higher with the hybrid knife than with conventional knife. However, in colon, as say Roberta, this knife is criticized because it is too stiff, and the best knife should be flexible enough, accurate, with high pressure, with a scene, with a good electrosurgical behavior, and perhaps with injecting viscous solution. Until now, we don't have it, but now we'll have it. It will come soon, in less than 12 months, is the hybrid knife flex. Here you see the picture and the design of this hybrid knife with the length of the probe that is 1.5 and with a T-part that is 1.2 millimeter. That's work, and that is perfectly stable, and that works very well in retroflexion. You see the stability of the knife and the stability of the probe. And we have been lucky guy with Professor Noyos and Professor Repici to test it on animals in a randomized trial in pig. The idea was to evaluate the performance of this wonderful knife against what is called the standard, that is dual knife G. The primary endpoint was to evaluate the performance of this new knife in a non-inferiority trial. Here it's how it's work. You see it's all-in-one knife, as was telling Roberta. With ability, you will see the wonderful injection ability that is only possible with hybrid knife. And you will see the difference with the old one, with the accuracy of the cutting and the speediness of the cutting and the flexibility of the knife. You cannot see this, but I can tell you that when we have it in our hand, it was for me a revolution. And since more than 1 year we test it, I'm looking for having it in human, and we are very happy that I know that the CE marking is coming very, very, very soon, and it will be for me clearly a game changer for colorectal ESD. I advance a little bit. You see the perfect reinjection, and you don't perhaps know if you never perform colonic ESD in pig, but colonic ESD in pig it's more and more challenging than in human because it's very, very, very thin, and the muscle layer is very thin. And despite this, you see the accuracy of the procedure with this knife, with the high pressure injection that can we use and reuse every time. I will try to move to the end. Okay, one example of the specimen. The performance, we show that the hybrid knife tip 2, the flex knife, was as good as a dual knife and even better for injectionability, for hemostasis, for working with cushioning. And if we pull all the aspects that we have to discuss with the engineer, we find a significant difference of the performance aspect of the hybrid knife flex versus the dual knife G. Don't forget also when you do ESD, when you train to ESD, to evaluate yourself is the picture of the datasheet that we share for all our friend group. We have all the same datasheet and we try to evaluate and to see each other and to share all our idea. And don't forget that never stop for training for ESD. And for the conclusion, ESD is much easier, but will not become easy. Do not forget to think about all these key points that we discuss in this lecture. Never stop sharing and training, and the new hybrid knife flex that comes very soon will be a game changer for colorectal ESD. Thank you for your attention.
Thank you, Jeremy, for your excellent presentation, and also really looking into the near future, because as you mentioned, the CE mark is coming soon, and then we get access to this very promising knife. Do you think it will completely replace the traditional, the legacy knife, or is there still an advantage of the somewhat thicker and less flexible knife in the upper GI tract when we have a thicker wall, more vessels?
Yeah, I agree with Roberta. I think for me, in particular for POEM ESD, I think I will continue to use the old knife, in particular also for the hemostatic ability, for the big vessel at the GI junction. For esophageal, I'm not sure because I clearly like the accuracy and the speediness of cutting with a smaller knife. For gastric, I think it could be also interesting because the mucosa is more thick and having a long length of the knife, it's not a disadvantage. And I say also, Roberta, sometimes to increase the stiffness of the scope in the gastric part, it's very easy. But for me, for colorectal, in particular colonic, it will change everything, but not only against the old knife, but for all the competitive knife in the market.
Thank you. Stavros, are you still with us?
Yes, I am.
So do you also dream on this knife? Or do you think...
Absolutely. John Day teased me by having me play with it on a pig stomach in July. I'm like, this is going to eliminate the competition in the United States, especially in the colon. We're not going to mention other companies' names, but one particular one who's going to be very sad about this knife.
And what did John tell you? When do you expect to get the approval?
You know, I don't have a firm. I don't think we have a firm time as you have in Europe. Unfortunately, I'm not sure.
But you can do some procedures when you are back home in Greece, huh?
Yes. Yes.
So it was. I think, unfortunately, we have to close this symposium. I think it was really extremely interesting, and we are looking forward to new technology. Even we need further improvement of ESD. Not all have this natural skill as our Japanese colleagues like Yutaka, but we need, especially in the Western world, additional assistance. And I would like to thank the speakers and thank you, especially Stavros, for getting up so early. Now, hopefully you have a wonderful day. We're getting close to the end of our first day in Düsseldorf, and see you back then in the main hall for continuation of the live demonstration. Thank you, and I thank Erbe for the organization and for the kind support. Thank you.